Welcome, everyone. The title for today's webinar is A Conversation About Racism in Medicine. Objectives of this talk are to begin to understand the constructs of race and racism, learn about the connections between racism and medicine, and to begin the journey of self-reflection and unlearning that is necessary to disrupt racism and racist structures. Our speaker for today is Dr. Kasia Johnson, who is a developmental pediatrician at Ron Joyce Children's Health Centre in Hamilton, Ontario, a Bethesda in St. Catharines, Ontario. Dr. Johnson completed her training at McMaster University in Fine Arts and then continued her journey into medicine. She completed her pediatrics residency at McMaster and then her developmental pediatrics subspecialty training at Holland Bloorview Kids Rehabilitation Hospital in Toronto. Dr. Johnson's clinical focus has been with children with a variety of neurodevelopmental diagnoses and children and families facing adversity. Dr. Johnson is the physician-led for the Canadian Pediatric Society's anti-racism strategy. Please welcome Dr. Kasia Johnson.
Thank you very much for having me here tonight. So again, I'm Kasia Johnson, and we're going to have a conversation tonight about racism in medicine. One of the things that we're always asked to do is present that we do not have any conflicts of interest. I haven't received any payment or supporting any products that may be mentioned in the presentation. However, I carry biases and I sit in a position of power and privilege in society as a physician. I am the lived experience of intersectionality where race, gender, socioeconomic status, and other factors are intertwined. I'm committed to understanding how this casts a lens on the information I am presenting today. And the other thing I should add, I am happy to receive feedback about the information that I am presenting today also and have a conversation about that. So to begin, I think it's important that we complete the land acknowledgement. We acknowledge that McMaster University sits on the traditional territories of the Mississaugas and the Haudenosaunee Nations and is within the lands protected by the Dish with One Spoon Agreement. This is a treaty between the Anishinaabe, Mississauga, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. The dish, or sometimes it is called the bowl, represents what is now Southern Ontario, Great Lakes to Quebec, and from Lake Simcoe into the US. All who live in this region eat out of one dish, all of us that share this territory with only one spoon. That means we have to share the responsibility of ensuring the dish is never empty, which includes taking care of the land and the creatures we share it with. Importantly, there are no knives at the table, representing that we must keep the peace. The dish is represented by the wampum pictured there. The other thing I always like to add to this land acknowledgement is a moment of pause. When we think wherever you are in this virtual world, please take a moment to reflect and give thanks for the traditional lands that you are sitting upon today and occupying today. Our objectives today are to begin to understand the constructs of race, racism, and racialization. Learn about the connections between racism and medicine, and begin the journey to self-reflecting and unlearning that is necessary to disrupt racism and racist structures. But our agenda also has the points of telling stories. We have to listen, and feel feelings, ask big questions, get grounded and connected so that we can start a path forward. The Youth Wellness Center offers these norms because this topic can be quite traumatic for people, and it can bring up uncomfortable emotions and feelings. So please take care of yourself, share and think, and know that everybody is on this journey and that people cope in different ways. Today's vocabulary. I'm a developmental pediatrician, so a pediatrician first, but also someone that realizes that we are on this journey of learning. So our vocabulary for today: race, racism, racialization, intersectionality, microaggressions, adverse childhood experiences, toxic stress, systemic and structural racism, tropes, and so the social determinants of health. So let's define some of these terms and ideas, and we're going to start from the beginning. Let's think about race as a construct of power. Race is a false construct because it actually has no biologic or scientific basis. So race is actually origins that have been connected to behaviors that have been linked to capacity to divide people into groups. Racism is taking race and connecting characteristics, then we apply meaning to those, inferior, superior. And racialization is the process of legitimizing these meanings. And that's done through historical, political, and social constructs. Race is a fallacy. This is a fabulous article by a young woman from British Columbia, and she says, sometimes I feel like an undercover Black woman. She is biracially, but she's generally perceived as white because of her light skin tone. Race is something that is applied to people. She describes that when people say racist things to her, they're assuming she's not a person. And so I use this diagram to say, when do those hands change from white to Black? We don't know. And when we think of racial tropes, where have these ideas come from? It's hard to think about that these ideas that are there, that we are raised with them. Our brain is shaped around these ideas, and they come from everywhere. And what we don't like to admit is that they govern our thinking and our behavior and our actions, and they have built our systems. So we go back. This is, you know, everyone likes to pick on the media, but we go back and we talk about blackface. And that's a 1900 theater advertisement where when people that are determined to be Black were not allowed on the stage, but they would have blackface to represent the characters. Sadly enough, our Canadian Prime Minister, current Justin Trudeau, is pictured there at a Halloween party in blackface. I don't know the age of everyone in the crowd tonight, but those of us that were raised on movies of the 80s and 90s, the Hollywood movies, if you saw a Black guy, you know he was going to be the first guy to die. And these tropes, these ideas have been created. So now you can show a Black man in a hoodie and assume that he is playing the role of drug dealer or gangbanger. The movie can move on because we put that trope in there so that we understand what it means. We get a general meaning to move the story along. The problem is those meanings are in our real lives. They're not just in Hollywood. This is a piece of work. One of the things that you should know about me, before I went into medicine, I did an undergraduate degree in fine arts, so painting, drawing, quilt making. And so understanding, you'll see it through this presentation, is a lot of visuals, but also looking to learning from art. And so this is a young woman that created this photo series about racial microaggressions. And these three sort of spoke to me about that idea of a racial trope. And when people ask the first young woman there, what are you? Her answer is human. Being biracial doesn't make me a what? And Courtney says, you know, I never see you as a Black girl. So what is a Black girl? Where is this idea that one person, one idea speaks for all? And the bottom one there, you don't act like a normal Black person, you know. This young man put this out after we sadly were subject to the horror of watching George Floyd be murdered on media, in the media. This young doctor put out this video on TikTok, and he says, if you celebrate me in my scrubs, don't hate me in my hoodie. Because suddenly he's the trope of fear and anger and aggression and badness that's associated with Black skin, particularly young Black men. So we have these ideas of racism, the individual, the institutional, the systemic, the structural. We have the person where there's the implicit, the thoughts, the explicit, the vocalizations, the interpersonal that happens between people. The internalized, when I hear these things about myself, when I'm in this space that tells me I'm not okay, I'm less than, I'm bad, how do I internalize that? And then I receive these microaggressions, those comments that are just a comment, an innocent, an observation. But what does it do? They're arrows pictured there because it hurts. But all of these relationships, all of these interactions are based on systemic, institutional, and structures that have been built to make us think this way. It's a hard thing to realize and understand. I'm not sure how many of you have heard of the adverse childhood experiences. Dr. Vincent Felitti and Dr. Robert Anda worked in California at a large, and it was the focus, the patient population was around diabetes and obesity management. And in the history of this development, they started to understand that a lot of their patients that were experienced this severe obesity and diabetes had trauma histories. So they built up a database and understanding adverse childhood experiences. So those things that happen prior to the age of 18 are pictured on the left, the experiences of physical, emotional, maltreatment, substance use, mental health, care providers, divorce, incarcerated member in the household, and then those outcomes that look like the right. Behavioral being lack of physical activity, smoking, alcoholism, drug use, missed work, and they connect through to the physical and the mental health, obesity, diabetes, cancer, COPD, and suicidal attempts. So long-term outcomes that are triggered, are a cascade from those adverse childhood experiences. Because with that adversity, you are experiencing what we call toxic stress. So everybody experiences stress. Coming on to do this talk, and I'm not sure if you know, but I'm connected via Zoom to Spencer, who's connected to you by Microsoft Teams. My stress is up because my technical abilities are, have not made this work as consistently as it should. But so I go from green into yellow, temporary stress responses, and it's buffered by the positive relationship of meeting Spencer tonight and him making it all okay. And so I can go back into the green, where my stress hormones can come down and they can let me fumble through this talk with you. But the issue is when you're experiencing those adversities, you get pushed into the red and you can't come back into the yellow. Because remember, we talked about those are buffered by supportive relationships. Well, those people around you that are experiencing those adversities, are experiencing those poor outcomes, may not be able to be providing those supportive relationships that buffer that response. So you end up in this red zone of toxic stress, where there's the cortisol responses, there's inflammation, we have changes in DNA transcription. So not actually changing the DNA, but changing the way it's read. That's affecting those outcomes, that's leading adversity to those outcomes. And so we see adverse childhood experiences. This is a lovely graphic by the World Health Organization that shows them as the grounding of the pyramid that builds up to early death, because you have the social, emotional, and cognitive impairment. You adopt health risk behaviors that leads to disability, disease, and early death. We know about this intergenerational experience of the adverse, the ACEs. And so the somewhat blurry graphic on the right there shows us that, depending on when they've looked at the number of adverse childhood experiences, 1, 2, 3, when you hit the golden number of 4, the adversities of your risk of being involved in alcoholism, of experiencing health problem, mental health problems, are all those astronomical, 1,000 times, 3 times, 87%, these astronomical increases. But the issue is that it's intergenerational. So this person has experienced that and is having the poor outcomes, and they're raising this person. And being a pediatrician, this is something that is in everyday practice. You know, I'm talking about racism in medicine, but this is the actual. You're seeing patients that are experiencing life outside of your office or your hospital. So we know that ACEs influence adult life, which in turn then influences the children. So we're talking about the adverse childhood experiences. But where is racism? When you look at the data from the adverse childhood experiences that has been propagated, started here and has gone, you know, at least through North America, if not Europe and more internationally, racism was never a question that was discussed as an adverse childhood experience, because the original data set didn't ask the question of how race has to do with this, because the HMO was college educated, middle-aged white Caucasian women. So race was not a question. Race was not part of their experience, of their direct experience in the world. But where is racism in this idea of adverse childhood experiences? So let's think about the real life effects of race, racism, the process of racialization, intersectionality, and that idea of adverse childhood experiences. The great Martin Luther King said, "We are not makers of history, we are made by history." So how has medicine made this model? This is a great course that's referenced along the bottom there. It's a MedEd portal, free course online, and it talks about the history of medicine. We're going to take a very jaunt through this to try and start to understand how the historical, political, and social constructs have shaped the systemically racist system that is healthcare today. And as this is an American course, I've tried to feed in some international and some Canadian references to try and push us, because it is not just in America. But we start with the 17th century of slavery is established in the United States of America. But we move to Sweden in 1758 when Linnaeus, the father of taxonomy, a physician, links geographic origins, skin color, and character. And this is to make the point. We always talk about anti-Black racism with slavery in the United States. Slavery has a history before the United States in Europe, when we were bringing people across the water to do the same things. Dr. Carl Linnaeus made this connection where we could say that Europeans were fair, gentle, acute, inventive, and governed by laws, and the Africans were Black, crafty, indolent, negligent, and governed by caprice. The Asiatics were sooty, severe, haughty, covetous, and governed by opinions, and the Americans were copper-colored, obstinate, and regulated by customs. It's this idea that somehow skin color has a political space, has a social meaning, and this is providing our historical context. Oops, sorry, wrong way. So we come to 1839 when Samuel George Morton, again a physician, measures skull to prove a racial hierarchy. And he makes it a proxy for intelligent. The conclusion, larger skulls give Caucasians a decided and unquestioned superiority. In 1876 in Canada, we established the Indian Act that has implications, for the healthcare of Indigenous people today. The Indian Act governs the boundaries for land occupancy, access to resources such as water and healthcare and education. We are still seeing the fallout today of these colonial actions that are perpetuating trauma, adversity, poverty across generations. And there is a slide, a point that I have not included here, where I hope that you're learning about residential schools with our Indigenous people and the removal of them, and horrific things for many, not all, but for many. And one of those things was, if any people in the audience have children, you may be feeding them infant pablum, the flaky, powdery stuff that's one of the first things that you eat. And it was developed by a physician, a pediatrician, long deceased, that had worked at Sick Kids, that based it on the starvation trials that we did in the residential schools, to understand what the nutritional needs are. Now, you may be having moments, as I said during this talk, when this information hurts. This information makes you feel uncomfortable, guilty. And we have to sit with that and understand what that means and carry forward. In 1932, the US Public Health Service begins the Tuskegee syphilis study. And doctors begin to monitor the progression of untreated latent syphilis in 400 poor African-American men, illiterate sharecroppers that were not told of their diagnosis. They leave the men untreated even after the discovery of penicillin, which treats syphilis. And they are actively discouraged to seek treatment so that we can understand the awful death and what it looks like for latent syphilis, the learning that comes from that. I had a colleague, and we recently presented, if anyone has ever had a vaginal speculum exam when they need to see your cervix. And that, again, was a tool that was developed because when slavery was stopped, they were no longer able to import slave children. And so the slaves had to have the children to keep the farms going. And to do that, they needed to ensure the health of the female slaves. They needed to treat different fistula concerns. And so the speculum was developed that has since saved many women's lives, but it was built on this historic fact. In 1964, Ashley Montagu publishes Man's Most Dangerous Myth, The Fallacy of Race, 1964. This leads to the broad conclusion that race should have no standing in science and medicine. But we move on. In 1976, there's a hypothesis, the slavery hypothesis, used to explain how high rates of hypertension among African Americans were a genetic difference, so that their slaves could survive in the traverse across the ocean. We now know that hypertension is higher in the African American population, but that's because of all of this history, the racism, the social determinants of health. And sadly enough, we are still teaching some of these erroneous facts, such as the nervous system in Black people is deeper, so that Blacks do not sense pain in the same way. They didn't sense pain when there were lashings, when they were slaves, but they needed to support their families. They needed to go to the fields and work, so you could not show pain. That does not denote a genetic difference. It's a coping, a life-saving coping mechanism. And we move on. In 2005, the FDA approves a drug that's identified for self-identified Black patients. But what does that look like? And so this heart medication makes the erroneous connection, again, that there is a genetics of race. It signifies that race has a distinct geography, ancestry, or genetics. And in 2020, the reason that we are meeting in this remote way, we're dealing with COVID-19, and it shows the long-standing effects and the history of systemic racism as we are documenting in Hamilton, in Toronto, and across the country, the higher rates in Black and Indigenous communities now. The interesting thing that has been the history in Indigenous communities is the effect of these pandemics, these epidemics that rage from the into the Indigenous communities, often occur 6 to 9 months after the original findings outside of the communities. But the sad thing is, prior to COVID-19 in Canada, we did not keep race-based data, health data, to understand the implications of this. And you may be wondering about, if race is a fallacy, why do we need to keep race-based data? Because we are currently operating in a systemically racist system, and we have to be able to count something to understand this, to start to move forward. So we have to start somewhere, even if it is not the ideal place to start. Systemic racism is the masterful set of policies, practices, and procedures that are historically, politically, and socially built to exclude, harm, and oppress. And so we have that idea of the racial tropes in media. So what are the racial tropes in healthcare? So we talked about this idea of tolerating pain. And in fact, there is a lot of data to show that in emergency rooms, repeatedly in clinics that are seeing racialized patients, that they are prescribing less pain medication. So one example is with sickle cell disease. I don't know if anybody knows that, but it is a difference in how the hemoglobin inside of a red blood cell that is normally round and flows through the vessels when it has oxygen tension due to illness, low blood volume, high altitude, it sickles. So it actually creates this shape. And then what happens is the sickles clump and they block blood flow. And so blocked blood flow causes extreme pain, and it can cause for organs that are downwind of that blood, downstream of that blood. The issue is sickle cell in children will often present with very obvious hot, red, swollen. But as an adult, as a young adult and an adult, that doesn't happen. And so you have Black people that have invisible pain that is extreme. But now you have to understand that they actually have pain, that they're not being loud, aggressive, scary, that they're not drug seeking. But these are the tropes that we have been taught by this history that puts us in this place to see race, to see the trope before we understand what the patient and the person needs. For our Indigenous brothers and sisters, we often think of high drug seeking. I don't know if anybody has heard of the unfortunate happenings where there was emergency room staff that were guessing the alcohol number of Indigenous patients in a British Columbia emergency room. We also have the case of Brian Sinclair from many years ago in Manitoba, an Indigenous man that died in the emergency room hours later after having been ignored because people assumed he was drunk and high, and actually he was becoming septic from an infection, from an untreated bladder infection. But we go on to think of our Indigenous brothers and sisters as being less intelligent and poor parents. And I put poor parents in there because these racial tropes affect all systems and structures. Children's aid societies, children that are being removed and being reported on, families that are being reported on. It is higher. The reporting, not the finding, but the reporting, the overrepresentation is in Black and Indigenous children in care, being removed. So we come to this concept of intersectionality, and it's the interconnected nature that Dr. Kimberly Crenshaw points out, that any one individual has these overlapping and independent systems of discrimination or disadvantage. So the experience of the Black woman is different than the experience of the Black gay man. So these ideas, these places, that you can sit as a Black woman, as a physician, in some places of power and privilege, in some places of distinct discrimination and disadvantage. So Dr. Stan Sonu, who's a pediatrician, adapted, so his is the picture on the top, and the reference across the bottom is the original reference to a new framework for addressing those adverse childhood and community experiences. And I love his adaptation because it shows those adverse collective historic experiences of slavery and genocide, Holocaust, forced displacement, mass incarceration that has created the toxic soil that's grown the roots of racism, unaffordable housing. So those start to be triggered and understand as our social determinants of health. They are grown from this toxic soil. And it only makes sense that they have to come from somewhere, because if they don't come from a system, they come from the individual. And how are this collective group of individuals making a collective choice to grow this toxic tree? But it's the systems that have created the soil that grows this tree, that grows into the adversity. Healthcare, medicine is built on this toxic soil. So these are the social determinants of health that I'm talking about. Those things that are grown from this, that affect outcomes. So your gender, your ability to secure housing, income, disability, early life experience, Indigenous status, all of these things to those life outcomes, but they are grown from that toxic soil. So we think about racism leads to health inequities. We have racism, we have psychological stress that all of this caused, the social determinants of health, the victimization of the system inflicting on all this, and we become healthy. So we seek healthcare, but we are seeking it in a system of systemic racism, a system that is built to see race before health. And racism doesn't just happen, as we said, in healthcare. We've heard about child welfare, and recently you may, I hope, have read about the unmasking of racism in McMaster athletics that has been used as an opportunity to change the story a little, but it's the same story. There's a clear culture. There's a clear idea, and these structures lead to behaviors that lead to experiences of racism, that lead to outcomes that are poor. So what if we started new today? Can we? Should we? This is Dr. Ibram X, who's the director of the Boston University Center for Anti-Racist Research.
What's the problem with being not racist? It is a claim that signifies neutrality. I am not a racist, but neither am I aggressively against racism. But there is no neutrality in the racism struggle. The opposite of racist isn't not racist. It is anti-racist. What is the difference? One either endorses the idea of racial hierarchy as a racist or racial equality as an anti-racist. One either believes problems are rooted in groups of people as a racist, or locates the roots of problems in power and policies as an anti-racist.
So I'm not sure with the relay through Zoom and to you on Microsoft Teams, but the idea there is that the problem is not rooted in the individual. The problem is rooted in the system that influences the individual. And to feel that guilt and say, well, I'm not racist. I have not done racist things. Those ideas may be definitely what we talk about intent. Your intent does not negate the harm. And so it's not okay anymore to say, I'm not racist. We have to work to be able to say, I am engaging in anti-racist activities, ideas, disruption of the system. So what are the elements of change? Often in healthcare, medicine, academia, we appoint an expert. So-and-so is an expert in this, and so holds that piece of knowledge. And what we're learning in medicine right now with the pandemic upon us is that nobody was an expert in COVID. And so there were people that know about infectious disease. There are people that know about epidemiology. There's people that know about public health, policy, education. And so we have to bring those 3, those 4, those 10 areas together to build expertise and knowledge. So in this, what are the elements of change to become anti-racist? We have to have those learned colleagues, that there are many at McMaster that are experts in critical race theory, the history, the change behaviors. We have to listen, and I put myself in the middle. But again, I should not do that because it's erroneous from the point of view that I do not speak for all Black people. I do not speak for the Black experience. As a race woman today, you may call me Black tomorrow. I may be thinking of myself as white, right? So it's the lived experiences where we have to bring that in to understand the experience. People will say to me, well, you're Black, so you can't speak about anti-indigeneity. Their experiences. You're right. I have not had the experience of being an Indigenous person, but I have had the experience and can talk of what systemic racism is and what it does to me. And they can speak about what it does to them, but the root of the problem is in the system. So then we talk about the culture of medicine, the culture of healthcare, the toxicity of the culture, and we try to break that down. But if we don't disrupt that, We're always just chipping away at the same thing. So a silly example that hopefully starts to tie these ideas together of the things that are acting upon us that we're not always conscious of, that we have to start to unlearn and wake to. As a physician in medical school, there's something that happens that only struck me when I became staff. Finished medical school, finished residency, and you become staff. And it's been a lot of work. And you're going in to see a patient, and then I have a medical student with me, I have a resident with me, and I have a fellow with me. And the medical student opens the door, and I step through the door first. Since when did I expect people to be opening doors for me? I did not realize that I had adopted that power dynamic, that power position where the person with the most power walks in the door. The person that opens the door is the person with the least amount of power. But when did I take that on? When did I walk in and think, right, I've arrived? And so I remember walking into the room, laughing as I'm entering the patient room. The patient has parents, and their parents don't have any clue why the doctors just walked in laughing. But it dawned on me that I had taken this on, that I had adopted this. This is one of those systemic ideas that I had been indoctrinated with, and nobody told me. But it's a behavior that you watch, that you engage in, and you start to develop that sensibility. And if you don't have those woke moments where you question, where's that coming from? What's that about? Is that okay? Is that right? We have to do that so that we have those moments. So there are the elements of change, but we have to overlay on them the personal thinking and growth and work that we have to do, the unlearning that we have to do. And then there is the systemic. Because what happens is we do a lot of the personal work, unconscious bias training, anti-racist training, read this article, read this book, buy this, bada, all of this personal work. And then we go back and we live and we exist in these systemically racist systems where I am not a racist, but I am partaking, I am a cog in the wheel of a systemically racist system, which means I perpetuate it. I keep it going. And it's a bit creepy here, but I've left my eyes sort of open there in the middle because it's the idea that our communities are watching. They're watching. There's a lot of performative change that happens. We strike this group, we strike this task force, and this performative action that doesn't lead to substantial change because it doesn't question the system. It's a group that operates within the system, and the confines of the system are not changed. The group can't change the system. So move beyond, do the personal work so that you start to hear and see these things, but move to the disruption of the system. So I like this idea here of a call to action. And as I said, being in art and never doing very well at photography, I'll admit that. But this idea that there's somebody who's behind the camera, who's in front of the camera, who wanted this picture taken? Who are we seeing? Who are we not seeing? And what will this image represent? And what will it not represent? Because when we think about a photograph, it's got a story that I could bring to it. It's got a story that somebody has given me. But it's also got a story that somebody is expecting me to see. Remember those tropes, those ideas that hit you and tell you something, and you don't even know that you've learned that something. So we talk about change behaviors. We have to start the process of unlearning. We have to be bold, get uncomfortable, feel it, lean into it, understand why. I hear that and I don't know what that is, or if somebody else hears it differently, why did they get uncomfortable? What did I miss? What did I not miss? We have to ask questions to dismantle the system. One of those things, and it's an idea that I haven't quite formulated, so go with me on this. It's the idea of when I'm presented tonight and my credentials are read, and my credentials give me legitimacy for you to listen, for me to be presented as an expert. And I've acknowledged that I am not an expert in critical race theory. I have a lived experience. I have an understanding of the culture, and I'm bringing that to this conversation. The only president of the United States who has been asked to prove his credentials of birth and education, Barack Obama, the first Black president. So when we start to ask these questions to dismantle the system, it's not to say that everything is going to change, but it's to say that we need to question everything, go through the thinking, and come to the other side and say, right now, with our current understanding, we are settled in this space. But if we don't start to chip away, we're not going to be able to change the outcomes that we're seeing. We have to get it wrong so that one day we might get it right. We talk to little kids now in grade school about the growth mindset, right? But we get to university and there's a right and a wrong, right? We get into medicine and you should never admit that you were wrong. But the thing is, we're going to get it wrong. We've been getting it wrong for a long time and just ignoring it and pretending like it wasn't there. But we've been getting it wrong for a long time. So let's get it wrong purposefully, so we're moving towards a system to get it right. The eyes and the ears are there. One of the things that I struggle with is when I have friends and colleagues that say they are allies to this movement of change, this movement of thinking. And I applaud them for coming on this uncomfortable journey. But what I struggle with is loving the term of ally, co-conspirator. But what I struggle with is when I'm in the moment and I experience something that feels to me like that moment of othering, where I know that nobody else is experiencing that. It's a moment that lays things out where we don't ask the next question. In hiring, we know that physicians, healthcare providers that are the same race as their patient decreases the poor outcomes. It cuts infant mortality in half, when there is the same race physician that's applying care to that infant and their family, participating in care, And so when I'm in a conversation where I say, with our next hire, can we hire somebody that is of a racialized community? And when the conversation comes around to, well, I don't think that's important. Or the conversation comes around to, well, I don't know how to do that. So in not knowing how, we then don't do. But I realize in that moment that those people that have said they're allies do not have their ears and their eyes tuned to the same way as I do, to these experiences, to these ideas, to the language. So on our journey to become a co-conspirator, an ally, and the thing is, I'm speaking about ally and racism. There are allies in the LGBTQ+ community, that people are allies. They are not of the community, but they're a co-conspirator and bringing about change. Tune your eyes and your ears. And I'm a physician, and I just pointed to my ears when I said my eyes. So, but we've got to tune our eyes and our ears to these ideas so that when we are there, we are hearing it through the anti-racist lens. Because it's only then can we start to question and dismantle and lean into the discomfort to do the unlearning that we must do. We talk about systems change. We can rethink, we can reimagine, we can reinvent, but we must disrupt, actively disrupt the system to bring about change. The great Martin Luther King Jr. said, "Our lives begin to end the day we become silent about the things that matter." So I say to you today, take action today, but take anti-racist action today.